Good morning, good afternoon, and good evening. I'm Mukta Sandhu, Senior Scientific Education Manager representing Geistlich Pharma, Switzerland. I'm very happy to announce that we have Professor Anton Sculean as our speaker today. If I have to give a brief introduction, I would say that he is a professor and chairman of the Department of Periodontology and currently the executive director of School of Dental Medicine, University of Bern, Switzerland. Professor Sculean has been recipient of many research awards in regenerative periodontal medicine, as well as he has received a Distinguished Teacher Award of European Orthodontic Society. He has authored more than 300 articles in peer-reviewed journals, 30 chapters in periodontal textbooks, and has delivered more than 450 lectures at international and national meetings. His research focuses on periodontal wound healing, regenerative and plastic aesthetic periodontal therapy, use of antibiotics, antiseptics, and novel approaches such as lasers and photodynamic therapy in the treatment of periodontal and peri-implant infections. So before I hand over to Professor Sculean, to make this webinar very interesting and interactive, please write down your questions in the question section, and we will address them at the end of the webinar. And if you have any technical difficulty, please write to us, and my colleague Artem Raskato will guide you through. Also, before entering our live session, question and answer session, a QR code will be displayed on your screen, which will allow you to avail the special offer that we are giving away today. And today we are giving away 50% voucher for the complete online curriculum of Geistlich My Guide, which is the guided learning journey of dental regenerative procedures. So thank you very much for being here, to all of you, as well as Professor Sculean. And I'm really excited to listen to you. So I hand over the stage to you, Professor Sculean.
Thank you, Mukta, for the introduction. I'm really very, very happy for being offered a chance to present some new data regarding concepts for soft tissue regeneration that have potential to be used around teeth, but also around implants. And basically, we would like to start with the problems associated with autogenous tissue harvesting. So if we harvest connective tissue or free gingival grafts from the palate, obviously we increase the morbidity, although we know that from a biological point of view, the autogenous tissue is still the gold standard. Another problem is the possibility of postoperative bleeding that may sometimes occur. And in certain cases, we may face a sensibility or a reduced sensibility at the donor site. Not very frequently, but it can happen maybe in 2 to 5% of the cases. This is in most cases transient, but it can be unpleasant for the patient. The biggest problem, though, is the limitation in the amount of soft tissue, because we may have patients that have multiple defects, multiple recessions, and we may not have sufficient tissue that we can harvest from the palate. Especially, we need to keep in mind that some patients have also recessions at the palatal roots, and this may generate difficulties in harvesting the connective tissue graft. Even if we are skilled and we have a lot of routine, we may need a longer surgical time to perform the surgeries. So, since many decades, colleagues and also our group has worked on testing and developing improving soft tissue replacement materials that have the potential to be used in certain clinical scenarios, should be, in fact, materials that mimic the autogenous tissue and can also serve as a carrier for biologics or maybe for other cells, or to be used in combination with a soft tissue graft, and also finally to replace completely an autogenous graft. But you will see that we are not always black and white. We have materials that can be used, but we still may need a combination of different concepts. So let me start with the first biomaterial that we have worked on since many years. Basically, we started our first investigation in 2009, so many years ago. And this material is a three-dimensional matrix that was, in fact, developed to mimic a free gingival graft. It consists of two different components, a three-dimensional matrix that mimics the connective tissue component, and also a kind of collagen membrane on the top that may mimic the epithelial layer. The material is biocompatible at a high level. It is also hydrophilic because it absorbs very nicely the blood, and it stabilizes the blood clot. So we started as first with some animal studies, looking at the integration of the material in different clinical scenarios using a dog model. And in these scenarios, we performed recession coverage at teeth and at implants using a connective tissue graft, using a coronal advance flap, or using a coronal advance flap in combination with a 3D matrix, namely with a mucograft. What you can see in this histologic image is, to the left, always the overview image of a tooth that was treated with a connective tissue graft and a coronal advance flap. What you can observe is a nice integration of the connective tissue graft into the surrounding tissues. We have a certain level of epithelial proliferation and an increase in tissue thickness. But of course, we all know that the connective tissue graft is integrated very nicely in the surrounding tissues, although in certain cases, we observed a quite prominent epithelial proliferation. When we looked at the cases that were treated with a collagen matrix, interestingly, the matrix integrates very, very nicely into the surrounding tissues. And you can see some overview pictures and high magnification, indicating a very limited amount of inflammatory cells, of plasma cells, and a very nice integration and almost a complete disintegration of the material while in contact with soft tissues. So basically, what we observed at that level is that there were absolutely no adverse reactions to the connective tissue or the collagen matrix. Interestingly, we had less epithelial proliferation using the collagen matrix, and we had a very nice tissue integration of the material. In terms of tissue thickness, we also observed a quite nice increase in tissue thickness, and we couldn't find differences between the connective tissue group and the group that was treated with the collagen matrix. So then we moved on to the clinical situation, and this is one case that was treated by one of my students. And you see the right indication to use this collagen matrix is in fact a case where we have recessions, class 1 or 2 recessions, and still some available keratinized attached mucosa or soft tissue, because in this case we can mobilize the flap or the tunnel. We like to use the modification of the tunneling approach. And one particular feature of this material is the very, very high hydrophilicity. And that means that the material absorbs the blood and it stabilizes the blood clot, which in one sense is very useful because it is very biologic. However, from the other point of view, the material is very, very difficult to be sutured alone. That means that we need to move the flap together or the tunnel together with the material in order to cover these defects. Very importantly, the material should not be left exposed on an avascular root surface. That's very important because it may disappear completely. When we look now at the healing after a couple of days, you see that we have very little inflammation and a very nice integration of the material in the surrounding soft tissues. Now, when I look at the case, and I look at the case after 3 years, look at the complete coverage of these roots, and when we look at the color and the texture of the newly formed tissues, this looks very natural. And this is, in fact, a very good indication for this particular material. Then when we look at the literature provided by other groups, I would like to point out this study by the group of Jepsen and colleagues. They did a randomized controlled clinical study comparing the collagen matrix with a coronally advanced flap alone. And in terms of coverage of large defects, the collagen matrix was more effective than a coronal advanced flap alone. The same findings were reported by the group of Moreira and Salum in 2016, and they also reported an additional small gain in keratinized tissue thickness after 6 months. Another study by the group of Tonetti and colleagues have compared the coverage of recessions using a coronal advanced flap with a control, that means with autogenous tissue. You see a quite high number of defects, more than 240, and the same number of defects that were treated exactly with the same surgical procedure but using the collagen matrix. In terms of complete root coverage, you can observe that the autogenous tissue performed significantly better compared to the collagen matrix. However, when we look at the surgical time was almost 16 minutes shorter in the collagen matrix treated patients, and the recovery time was almost 2 days shorter in the collagen matrix group compared to the group treated with autogenous tissue. And this was interesting to see because also the patient perspective needs to be evaluated in these studies. Another study by McGuire and Shire looked in a randomized controlled study and exactly at the same materials, the collagen matrix versus the connective tissue graft. And you see that the collagen matrix performed almost as good as the connective tissue graft, and the results were stable in both groups up to 5 years. However, we have to point out that the collagen matrix has lost some of the coverage after 5 years, and you can see the numbers: 95%, 96% root coverage, mean root coverage after 5 years with the control, that means with autogenous tissue, versus roughly 78% with the collagen matrix. However, when you measure it, it is very difficult to make the difference between 90 and 80 or 95% and 80%. However, the tissue color match to surrounding tissues was very similar for both groups. And the patient satisfaction reported no statistical significant difference between the treatments at any time point. Now, when we look at the treatment of multiple class N2 gingival recessions using the same materials and the tunneling approach, we performed a randomized controlled clinical study in which both groups were treated by the same surgeon, by Dr. Aroca. And after preparing the tunnel, the control group received the autogenous tissue harvested from the palate, whereas the test group was treated with a collagen matrix. And you see the harvesting technique that is well described in the literature. The randomization envelope was always open after the tunnel was prepared at both sides in order to avoid a bias. The material was covered in every single surgery, and then the results were reported and they were evaluated at 1 month, at 3 months, at 6 months. You can see the changes in the tissue texture, in the coverage, in the thickness, up to 12 months. And what we observed that both groups performed significantly better compared to baseline. However, the duration of surgery and patient morbidity were significantly lower in the test compared to the control group. Now, when we look at the 9-year results, and this is a more recent evaluation of the same material, we have obtained positive results, especially in cases where the patients displayed still keratinized tissue of about 2 to 3 millimeters. In these cases, the coverage was very predictable, both with the collagen matrix and the connective tissue graft. However, when we look at the outcomes comparing the maxillary with the mandibular arches, it is very interesting to note that in general terms, the mandible, that means the lower jaw recessions, performed less good with both treatment options. However, the collagen matrix performed significantly better in the maxilla compared to the mandible. And this leads me to the conclusion that when we use the collagen matrix, it is very, very important to look at the correct indication. Namely, we have to select cases where we still have at least 2 to 3 millimeters of keratinized attached tissue. So this is very, very important. If you don't have any attached gingiva, then we need to use autogenous tissue. So this is very important for the decision-making process. Now, when we look at another biomaterial that we have tested in the last years, is a three-dimensional cross-linked matrix, like a sponge, that's called Fibro-Gide. And this material is very interesting because it is volume stable and has the capacity to stabilize the blood clot and also to serve as carrier for biologic active substances. So let me show you one of the first studies that we conducted. And this study looked at the potential of this matrix to attract cells, namely periodontal ligament cells, fibroblasts, gingival fibroblasts, and human umbilical cells that have a high differentiation potential. So now when we look at the migration and the proliferation of these cells over the matrix, you can see a huge difference between the test and the control. And all these cell types proliferated very, very nicely over the substrate. You can see this dark staining indicating a very dense population of the cells over the matrix. And also the same is indicated in the bar. Now, when we look at the potential of this matrix to absorb and to release different growth factors and biologics, we have used the matrix in combination with TGF-beta1, PDGF, FGF2, and GDF5. All these growth factors are very, very important for soft tissue healing and also for periodontal wound healing and regeneration. And what we can observe in this slide is that we have an absorbed protein of these growth factors, that means almost 100%, while the protein release was going on up to almost 2 weeks. And this is very important, indicating that the matrix can be used as a carrier on a long-term basis for different biologics. And we also tested in hemimetics proteins, because in hemimetics proteins, that means the product called endogain is used routinely in the clinic. And I wanted to see whether this material can, in fact, be used as a carrier also for this kind of biologics. Another important effect of this collagen matrix was the so-called anti and pro-fibrinolytic potential on the wound healing. And basically, we were able to demonstrate an anti-fibrinolytic gene expression. That means the genes that stabilize the blood clot. For example, thrombomodulin, plasminogen activator inhibitor type 1, spondin 1, F3 tissue factor, that is the thromboplastin. All these have an anti-fibrinolytic gene expression. They are very, very important to basically stabilize a blood clot in the first event of the wound healing. And then we also observed pro-fibrinolytic gene expression. That means the genes involved in the lysis of the blood clot, like the tissue plasminogen activator, the urokinase type plasminogen activator, the urokinase receptor, the matrix metalproteinase 14 that acts as fibrinolysin. So basically, we were able to demonstrate that the volume-stable collagen matrix strongly contributes to soft tissue healing process. And in fact, we continue our research by looking at the effect of this collagen matrix on the regeneration of peroneal wounds in a dog model. And basically, the experiment was very simple. We only wanted to see whether this material is able to stabilize the blood clot. We created non-contained type defects, and these non-contained type defects were treated either with a collagen matrix alone, or they were left empty. Look at these histologic images. To the left, you can observe the overview, and this is a control. That means open flap debridement. And the control illustrates very clearly a proliferation of the epithelial cells, almost up to the most apical part of the defect. At a higher magnification, you can clearly observe the epithelial cells that proliferate from coronally to apically along the root surface. However, when we use the collagen matrix, what we observe is, in fact, a very nice regeneration of root cementum coronally to the notch, peroneal ligament, and bone formation. Bone formation just due to the activity of the collagen matrix, because the collagen matrix was able to stabilize the blood clot. At a high magnification, please observe the newly formed cementum on the root surface. We have the peroneal ligament space and bone formation, indicating the biologic potential of this material. And at a high magnification, you can clearly observe the bone with inserting collagen fibers. And this is a unique feature that we have observed for the first time. What is now the clinical relevance of these findings? And let me show you some cases, because in certain cases, with a correct indication, I started to use also the Fibro-Gide, but it is not so easy, because you have to have first a proper diagnosis. Again, I want to point out the correct diagnosis and indication. These are patients that have at least 2-3 millimeters of attached gingiva. Basically, I create a mucoperiosteal tunnel. I release the fibers, and then what I do is to make sure that I have my collagen matrix that needs to be cut in slices, because otherwise we cannot, in fact, insert it in the tunnel. I stabilize the papillae. I fill my tunnel with this material, but then we cannot suture the material by itself. So we need to suture it together with the soft tissue flap or the tunnel. So basically, I use, in fact, one sling suture that encompasses and penetrates through the soft tissue, through the grafting material and moves the entire complex coronally, covering the recessions. So the surgical technique is a little bit different to that what we have used until now. And then after the healing process, you can observe a very nice coverage, in this case, until the cement-enamel junction, indicating that this material can be used for this particular indication. Look at another case. This was a challenging case. And for me, this is also a very important indication for this material. In this particular case, I was facing a patient that had a bone loss between the lower incisors. Then we have also loss of papilla, interdental papilla. We have a very strong pull of the frenulum and almost no keratinization, no tergingiva, very thin tissue. However, we have also a situation at the canine where we have a deep recession, but still 2 or 3 millimeters of keratinized tissue. So what I did in this case is to prepare a tunnel, and basically the indication for treating these defects is to improve the medium to long-term tooth prognosis. Because if you do not increase the stability of the soft tissues and do not attempt to cover these defects, what may happen basically is to have a deterioration of the situation that may even lead to tooth loss over time. So what I do is to prepare a mucoperiosteal tunnel using the tunneling instruments. That was not so easy because the tissue is a more skull-like tissue. So I like to use my specially developed tunneling instruments, staying with a cutting surface on the bone, using the tunnel instrument basically like a kind of periosteal elevator. Then I have an intracircular incision. Then I move my tunnel preparation more distally to the canine. I lift the papilla. Look at the invagination that we have. This is very dangerous because it can perforate very easily. You see this invagination between the canine and the lateral incisor. It is very important to release also the muscles. So I like to use this so-called microsurgical long blades, the Kidan blades. Very, very carefully, releasing also the fibers, moving the tissue coronally. I'm going under the papilla and over the crest. And also extended a little bit the tunnel. So of course, my protocol is always to try to use only in the situations where it is very, very challenging from a biological point of view, autogenous tissue. So basically at the 2 central incisors, I use autogenous tissue. However, the rest of the tunnel is going to be filled with a collagen matrix. You can observe how challenging it is to lift the papilla. look at this invagination that can perforate, so it may lead to a slight perforation, but this is not a problem since we are going to close it and fill it with either connective tissue or with a collagen matrix. Another tunnel is quite mobile. And now you will see how we move forward. This is very important to check with the curate. Then I harvest the connective tissue graft from the palate. Using the single incision technique, closing everything. This is my connective tissue graft. Then we can use also biologics. I like to use either nematocytic proteins. We can use IPRF or hyaluronic acid. I like to use a cross-link formulation. But the most important is not the biologic, but the connective tissue graft. I have to point it out. That's very important because the connective tissue graft has living cells that will enhance keratinization and also growth factors. Did you see the way on how I pull the graft in the tunnel? If we have a limited space, I always go vertically, and then I move the tissue more laterally, mesially and distally, using the Cooley pliers and the tissue pliers. The tissue plier is the tweezer with a small hole, which enables me a very precise suturing. And then I fix the graft. How do we fix the graft? With a sling suture. So the suture for the graft is going to be fixed always lingually. It's very important. Now I move the tunnel coronally, but I can also have a specifically designed suturing technique, namely a lateral closure combined with a coronal advancement. So I close the tunnel with the so-called double sling suture laterally. And this has also the advantage that I can use, in fact, also the frenulum as a kind of small flap to cover the graft and the recession. However, the neighboring tooth needs to be addressed with a coronally advanced sling. So a sling suture that will move the soft tissue coronally. And I like to combine the sling suture with another suture over the retainer. And if we have real strong tension from the lip, that of course has been released, I like to release the fibers completely from the apical part and then use another sling suture to move also the mesial part of the tunnel over the retainer. So this will give a very good stability for the entire complex. Now we still have the recession at the canine. And you can see this problem here. We don't have now enough connective tissue graft. So what I do in such a case is to use my 3D collagen matrix in order to stabilize completely the entire complex, the entire area. So now we take the material. However, please keep in mind that the material cannot be sutured alone. When you insert the material in the tunnel, you need to be very careful, cut smaller pieces, smaller slices. And the main thought is to fill the tunnel mesially and distally, and also to fill the papillae, to undermine the papillae, because in this way, I can very nicely stabilize the entire area. You can see how I insert it. I have stabilized it. And now I use two sling sutures, one wide sling suture that encompasses the mesial and the distal papilla going to the basis, and I pass through the soft tissue and through the collagen matrix. And then a second one that will encompass the middle part of the recession, very deep, but of course, the knot will be placed now in the other direction, mesially. So we don't place the knot always in the same direction. But that's very important. And I over contour a little bit the recession. So here I passed with my suture through both layers. Usually I remove the sutures, especially in the mandibular area, after 3 weeks. So I always check the mobility. So look, when I move the lip, the treated area should be stable. Now let me show you the outcome. The outcome indicates in this Miller class 3, almost 4 recessions, roughly 85% coverage, and the complete coverage at the canine. So this is for me a very good indication to combine in different situations, difficult situations, the collagen matrix with the autogenous tissue, and to take the advantage of both materials. That means the biological potential of the autogenous tissue with the mechanical and biological potential of the collagen matrix. And if you look at the texture of the tissue, you can clearly see that, in fact, we don't have any longer these undercuts. And this is very useful for the maintenance phase. Now, let me show you another indication for this 3D matrix is to be used for soft tissue augmentation at Pontics. And this is such a case. This patient was referred to me for soft tissue augmentation because due to the huge bone loss, an implant placement was very difficult and would have included a bone grafting and also maybe a soft tissue grafting. So it was very invasive, and therefore they decided to use only kind of Maryland bridge. that may, in fact, be easy to correct later on, and it is also very convenient for the patient. So for ridge augmentation, I like to use the following technique. I have an incision over the crest, and this is also performed with the microsurgical blades. Please observe here the loss of soft tissue. So basically here, the aim is to increase the thickness of the soft tissue. The aim is not to gain bone, but the aim is to increase the thickness both in the volume, vestibulo-orally, but also a little bit in the height. So I prepare a full thickness flap. This is a kind of envelope combined with a tunnel. Please observe also the inserting frenulum. So what I always take into account is the insertion of the frenulum fibers, and I perform always an internal frenulectomy. So basically, nowadays, I release the frenulum, I remove the frenulum always from the inner side of the flap and not from an external axis. And this is very important. So I release the fibers. One critical aspect to be considered when we use this technique and this material is not to have any tension. So this is very, very important. So that's why I prepare an absolutely tension-free recipient site, very important, because we need to cover it without any tension. And then I cut the slices from the Fibro-Gide, look at the way on how the material is inserted. So we have to press it into the defect. But immediately when the material is getting in contact with the blood, you can see how the blood is absorbed in this 3D sponge. And this is very important because it indicates the high biocompatibility of the material. And if we have the blood clot there, we have already all the growth factors. And this has been beautifully shown in the study by Asparuhova and by Jean-Claude Imber. That means that we have, in fact, a material that stabilizes the blood clot, and in an indirect way, it stabilizes and it helps the healing. That's why I always advise to use the material in a dry form. So I compress the material labially and also lingually. I over contour with about 20 to 30%. That's why we need to have a very mobile flap without any tension. And now the suturing technique is very important. So we cannot fix this material with pins. So what I do is to have a very deep cross horizontal matrix suture. And with this suture, I have two aims. One aim is to fix the material, to release the tension from the flap in order to allow a very good stability. So in fact, I have a cross horizontal matrix, but I do not pass with the tip of my needle through the matrix. Okay, I'm over the matrix. Now the material is fixed. It doesn't move. That's very important. We need primary stability. And then I close passively the papillae. Okay? How do I do that? By using double sling sutures. Because the double sling sutures are very useful, they move the tissue coronally and they close the tissue in 2 layers. Okay, so this is very, very important. So you see how I use the periosteal elevator to guide my needle. I use short needles, 12 millimeters, monofill, a little bit away from the tooth. Then it is a deep single interrupted suture, and then 1 layer more coronally, very close to the tooth, in the apical part of the papilla, another single interrupted suture. And in fact, in this way, I have 2 single interrupted sutures. Closing everything in 2 layers. Okay. So now it is important not to have any exposure. Look at the over contouring, also lingually. I also stopped the insertion of the frenula. And now when I look at the baseline and compare the baseline with the outcome, roughly 6 months later, we have a very nice improvement of the volume, not only vestibularly and orally, but also when I look at the situation from a coronal point of view. So we have also a certain, maybe only 2 millimeters coronal or vertical augmentation. So when I look at the situation from an incisor point of view, you can see the gain in volume and even an improved keratinization. So this is also an indication for the use of this material. So let me come to some conclusions, dear colleagues. I was hoping, or I hope to provide you new evidence showing that new matrices, new collagen matrices may really represent a future option for replacing connective tissue grafts or to serve as scaffolds for biologics and, of course, for cells. This is, for me, a very important indication. In certain clinical situations, medium or thick phenotype, not in very thin phenotype, soft tissue replacement materials may represent an option for replacing autogenous tissue, which in turn will minimize patient morbidity, thus improving acceptance. And with this, dear colleagues, I wish you a nice evening, and I'm looking forward to your questions. Thank you very much.